All right, everybody, welcome back. My understanding is the room is about 80% cardiology, 20% neurology, and that the cardiologists are both general and invasive. Does that sound right? Does anyone feel not represented by what I just said? All right, with that in mind, we're going to talk about a topic that affects all of the specialties I just named, cardiovascular risk reduction, which is including our stroke colleagues as well. We're going to again use the American guidelines as a focal point here, and we're going to discuss the strengths and weaknesses of that set of guidelines. And I'm very hopeful that you'll leave with a way to think about risk reduction beyond simply start a statin. Here is the outline we're going to use to do that. We're going to start with this concept of targets with our cholesterol-lowering therapies. Then we're going to take a step beyond that to discuss how to look for residual risk and all the different ways that that can look. And finally, I'll give you my version of how to approach statin intolerance and assessing whether or not we've hit our target cholesterol. If you look in journals in the 1960s, 1950s, an overwhelming thought was that we could not actually reduce cardiovascular risk, and it was all genetic. Fast forward to our latest iterations of guidelines, and you have charts that are very busy, like this, that show all of these different targets that we have to reduce risk. And I would argue charts like this aren't even complete. There are things that aren't mentioned on these charts that we can assess and treat. And so our goal today is to sort of expand from cholesterol outward to talk about how to minimize cardiovascular risk. I have to say a very common approach with my colleagues in cardiology is this. That's the ostrich burying his head in the sand to hide after he has started the statin, right? I kid my interventional colleagues sometimes when I say, "Do you do preventative cardiology?" And they say, "Yes, I start statins." I'm very hopeful we'll move beyond that in this talk. Nothing wrong with statins. It's a good first step. Okay. I really disliked the 2014 and 15 set of guidelines from America because they emphasized pick a group that needs risk reduction, start a statin, and then really you're kind of done. They got rid of the concept of targets, of how low should I lower my cholesterol. Here is the 2022 consensus update, which I really like, because it's reintroduced the concept of don't just start a statin, but start a statin and figure out how low you need to drive the cholesterol for that given patient. There's 5 basic groups that are going to be indicated for a statin. There are people who have had events, strokes or heart attacks. There are patients who meet criteria for familial hypercholesterolemia. There are adults with diabetes. And then these 2 groups are tricky. This group is adults in whom, after putting their numbers in a calculator, you are seeing an elevated 10-year risk of heart attack or stroke. And then this group's even trickier. These are people who, when you put them in the calculator, their 10-year risk is quite low, but their lifetime risk is quite high. And those are the 5 major buckets. And what I would tell you to do is each of these buckets can really be redefined as having elevated but not very high risk, and very or extremely high risk. And what we're going to do is we're going to go through these 5 buckets and we're going to figure out what are they. Are they elevated but not high, high, or very high? and then we're going to use this set of LDL targets for those groups. So when you deal with secondary prevention, you are inherently in a high-risk group. And the new expert consensus splits them up to say high or very high. The very high group is defined simply as having had 2 events or 1 event with multiple risk magnifiers or multipliers. Uncontrolled diabetes, elevated triglycerides, elevated lipoprotein A, something else that elevates their risk. The adults with diabetes and adults without diabetes can really be divided based on whether or not their 10-year risk is greater than or less than 20%. Meaning, in the next 10 years, is there greater than or less than a 20% chance that person will have an event? The guidelines, sort of perplexingly to me, it's confusing, but the guidelines suggest that if you have someone who's never had an event, but their LDL fits this higher than 190 mark, call them not high. I don't agree with that assessment, but that is what the current consensus update suggests. They're going to say, all right, so for this not high group, target 100. For this group, that's less than 20%, we're going to call that elevated but not high, target less than 100. For the young people, I already told you their 10-year risk isn't very high, it's their lifetime risk. So let's also put them in that bucket of just target 100. Then we go to our next group, the high risk. Already had an event but don't have multiple comorbidities. LDL should be 70. These 2 groups where the calculator said there's a 1 in 5 chance of an event, target 70. And then this group with multiple events, target 55. This is the new expert consensus. I wanted to go through it deliberately because many cardiologists start a statin and don't look again. But we should be starting a statin with some target in mind. And you've already kind of probably sensed this. I ignore less than 100, and I take everybody to less than 70. By the way, the European guidelines take this group and make their LDL less than 40. And the first time I told that to a group of internal medicine doctors at a big conference, they gasped. They were very surprised. I really like these guidelines. I'm told Wolf of Wall Street was not a popular movie in Vietnam. However, I really like these guidelines. Forgive my gif. And the reason I like these guidelines is it turns out this graph is one of the most powerful things in cardiology. There is no J point on this curve. The lower I take my LDL, the lower my risk. Every 40 points down, your relative risk goes down by about a 1/4. With the PCSK9 inhibitor trials, we know that this continues all the way to the single digits. However, it is not just lower is better, it's lower for longer is better. I find genetic studies like this very difficult to think about. But what this chart is trying to suggest is that the person who's been at an LDL of 190 for 30 years and then has their LDL dropped is going to be higher risk than the person who's had an LDL of 190 for 5 years and then had their LDL drop. A simpler way to think about this was introduced by Brunwald in an editorial a few years ago. And he said, just think about this as pack years of smoking. Smoke a pack a day for 40 years, that's 40 years of cancer risk. Smoke 4 packs a day for 10 years, that's also 40 pack years of cancer risk. Cholesterol, it turns out, behaves very similarly. Lifetime exposure to cholesterol drives events. The person who's never had an LDL above 70 is exceedingly unlikely to have a heart attack or stroke without introducing heavy tobacco use or something else. Conversely, these two are rapidly accumulating cholesterol years, and they start to see probabilistic chance of having an event increase early in life. Not just lower is better, lower for longer is better. Here's a perfect example of this. My team knows that this is not my LDL. However, if you plug me into the calculator, what you would get is a 10-year risk of 1.5%. That's very low. The guidelines would say, good to go, don't start a statin. But how good do you really feel in the office sending this person out saying, you don't need a statin, but your lifetime risk is 70% of a heart attack or stroke. Bye-bye, see you next year. I don't feel very good about that. This is a little bit of an aside, and I'm mentioning it because it's a myth that is pervasive even in cardiology land and neurology land. In America, politicians in the early 1800s were said to stand on soapboxes when they wanted to talk about their message. That's what this is, a soapbox. So this is my soapbox. HDL at very high levels is not necessarily protective. It turns out when your HDL goes above 80, lifetime risk starts to go up. Why? Well, it's complicated, but my suspicion is some people in this group might have fantastic HDL that's protective and low lifetime risk. However, in that group is also people with dysfunctional ApoA, HDLs that don't work, inflammation driving their HDL, alcoholism driving their HDL. And I can't tell you right now with our current testing, oh, don't worry, your HDL is protective and yours is bad. So ignore the ratio. Focus on the LDL. Okay. With all that said, we now understand how important it is to have target-specific therapy, really honing in on the LDL, but I'm going to shift gears a little bit now and throw a wrench in everything I just told you. This might give you flashbacks to medical school, but I'm going to simplify it. Chylomicrons and VLDL particles are primarily made of triglyceride. As they give away their triglyceride, they slowly become LDL. However, all of these particles cause atherosclerosis. So when you measure an LDL, you're getting some of the risk assessment, but you're often missing this. The next speaker is talking about diabetes, and about 1 in 3 diabetics have LDLs that underrepresent their risk because they have so much IDL and VLDL. In my clinic, once I hit an LDL target, I confirm that I'm at goal by ordering an apolipoprotein B. It's my way to make sure I'm not missing all this. And again, in America, 20-year-old studies suggest 1 in 4 patients have an ApoB much higher than your LDL would have predicted, and it's typically diabetics, it's typically smokers, it's typically people with previous events. Good. So I'm going to ensure my LDL is at goal, and then I'm going to kind of double check my risk assessment with an ApoB. This is a busy slide, but I think it hammers my point home. I'm going to draw a line there to simplify things, and I want you to notice everyone below this line has an elevated ApoB. They have variable non-HDLs and LDLs, but they all have elevated ApoB. And they all do worse than their counterparts. ApoB, Harold Bays, who was the former president of the National Lipid Association, said recently in a talk, I liked this, if we could go back in time, ApoB would be our marker in the statin trials, not LDL. ApoB is a better marker. All right, but all this focus on lipids actually misses a little bit of the picture when we talk about risk. The way that I explain this to patients is this. If driving your car off of a cliff is having a heart attack or a stroke, your current LDL is how fast your car is speeding towards the cliff. But the health of your blood vessels is how far you are from the edge. I can have an LDL of 240, but if my calcium score is 0, calcium score being a way to look at how healthy my heart blood vessels are, my likelihood of having a heart attack in the next 10 years is almost 0. If my calcium score is 1,000, my LDL of 90 is not nearly low enough. So to get the full picture of risk, subclinical atherosclerosis imaging is absolutely essential. By the way, if your calcium score is higher than 400, you've driven your car off the cliff whether you've had a heart attack or stroke. Your 10-year risk is already equivalent to having already had one or multiple events. Again, I want to hammer home for you, atherosclerosis imaging is the best way to understand a patient's risk. This proves that point. This is kind of a scary paper, but in this, Nasir looked at people in the 2015 guidelines who were recommended and not recommended statins, and then used the MESA database, a large data set looking at calcium scores, to see who had disease. 1 out of 5 patients who were not recommended a statin had coronary artery disease. 40% of patients who were recommended statins had none. Again, calcium score is the best way to understand risk. This hammers that point home. This is the pooled cohort equation and the MESA calculators, and it's comparing how well these perform with and without including calcium data. For those of you who aren't familiar, C statistic is a way of saying how good is my test at predicting what it's supposed to predict. And you can see here, when I add calcium score, I do much better at predicting outcomes than when I don't. Makes you want to go out and get a calcium score, doesn't it? Not the point of the talk, but when your calcium's higher than 100, you likely benefit from aspirin, primary prevention aspirin. And when your calcium score is higher than 400, I recommend aspirin because you're essentially secondary prevention. So again, it's helpful in using calcium score to determine what therapies to give the patient. All right, so we talked about we need to figure out where we're going. We need to figure out, did we get there? And we need to figure out how much risk there actually is. But let's talk about the patient where we've done all of those things, who's still at risk. How do we still assess for residual risk? Not the point of my talk, but smoking is bad. And we do a bad job of telling our patients to quit. When we study this over and over, in about 1/2 to 2/3 of visits, we say something, the other times we don't. And when we say something, there's literally a mortality benefit. Tell your patients to stop smoking, even if you've already told them. As you guys know, the epidemiology of this area suggests there's a lot of disability life years lost in smoking. Tell your patients to quit smoking. Even if you've told them before, tell them again. Exercise also is a very underutilized aspect of care, and I think part of it is because we tell patients you have to do 150 minutes a week, and that seems overwhelming. I have a hard time getting my kids to bed before 8 o'clock. 150 minutes of exercise seems like a lot. What we don't tell you, however, is that the biggest benefit of exercise is in the first 30 minutes. And it doesn't even have to be continuous exercise. You could do 3 10-minute bouts in a week, and you just achieved the majority of your benefit from exercising out of that 150 minutes. Park a little further away, get out of breath on the way into work. You can get 30 minutes a week. 150 minutes is hard. 30 is achievable. I'm going to have a talk on diabetes in a minute, but just keep in mind that there are diabetic-friendly drugs, and we should be using them in our patients with atherosclerosis. Another thing that we miss a lot is polyvascular disease. Just like the patient with cerebrovascular and cardiovascular atherosclerosis, the more blood vessels involved in the more sites, the worse you do. And PAD, peripheral arterial disease, is a big risk marker. Your patient is telling you, please reduce my risk. You have to diagnose it. You should also notice, this is a great chart from the Repatha evolocumab trial that shows of everyone, so the number needed to treat in everyone in that trial was 63, but when you look at the patients who have more than one blood vessel disease, meaning heart and stroke or heart and peripheral, they have an even bigger benefit of lowering cholesterol. So you gotta think about it, you gotta diagnose it, you gotta aggressively lower the treatment, and then there's increasing data that rivaroxaban 2.5 twice a day is helpful in this group. Out of the scope of this talk a little bit, but you have to think about patients with multiple vascular bed involvement. Okay, let's now talk about the other things in residual risk that a cardiologist could do or a neurologist could do. The first one we'll mention is LPA. Lipoprotein little a is an ApoB100 moiety, so it's in the same family as LDL, but it has this huge Apo little a protein that sits on the outside of the particle. The easiest way for me to communicate risk as it relates to LPA is that when your LPA goes above 50, you have added risk. When it's above 150, you should think that patient has an inherited cholesterol disorder. If it's above 350, you should think that patient has a gene-detectable cholesterol disorder and is 3 to 4-fold higher risk than what you may have considered otherwise. The nice thing about LPA is it doesn't change in life, it's flat, and so you check it once, you know somebody's LPA. Now, I will be honest with you, we don't know if this is a mitigator or a marker. What do I mean by that? When you start a fire, if you try to put out the fire by blowing smoke away, your kitchen and your house will burn down. You have to focus on the fire to put out the fire. I can't tell you that LPA is the fire, because it could be the smoke. Does that make sense? It could be that whatever's causing badness and recurrent events correlates with a high LPA, but the LPA is not causing it. And the reason I'm saying that is I don't have big trial data that tells you lowering LPA improves outcomes. But I do have data from the Repatha trials that show the higher my LPA was, the more I seemed to benefit from cholesterol lowering. And there are 70,000 people enrolled in phase 3 trials right now that should adjudicate in the next 1 to 2 years. We should be able to tell you what LPA lowering does for risk mitigation soon. My suspicion is it's going to help, but we should be able to tell you soon. Okay. Inflammation is another big next frontier. We'll start with the CANTOS trial. CANTOS, I think, got unfair press. This was a trial of IL-1 blockade. And if you look, those curves separate. There's cardiovascular benefit of canakinumab in this trial. However, the number needed to harm was very close to the number needed to treat, meaning I caused as many infections as I did prevent heart attacks and strokes. And the company priced this at 1.6 million per event prevented, which if you're a guideline writer, saying I'm going to write millions of this script that costs about $2 million American dollars per event prevented, that's a tough sell. So this ended up not getting approved in America, and they repeated the trial with methotrexate that's slightly higher up in the IL-1 pathway. And if you look, underwhelming result. So I think this is a proof of concept that lowering inflammation works. We just need to find the right drug. Some people suggest colchicine is that drug. And there were a handful of trials that show colchicine lowered risk. And the European guidelines have said, you know what? 0.5 of colchicine in a high-risk patient is a reasonable thing to do. My issue with this is the inclusion criteria of these trials is a little messy. And if you look at that MESA data set that I mentioned earlier, so that's the coronary calcium score data set from America, what you see is a huge swath jump between 1 and 2. Their CRP, C-reactive protein, jumps between 1 and 2. If the trial's inclusion criteria was 1.5, that means one day I made it into the trial and the next day I didn't. Did that patient change? I don't know how to begin to incorporate this medicine yet, but I think it's coming. The way that I think about it is, if everything else is perfect and you're still having events, I usually offer colchicine, but it's further down in my workflow. So if you thought inflammation was a mess and it gave you a headache, everything I just said, triglycerides is even worse. Triglycerides clearly are a sign of badness. Patients with high triglycerides do poorly. However, and we know when it's very high, triglycerides higher than 500, it causes pancreatitis, and pancreatitis can kill you. So if it's higher than 500, treat it. This is the compendium. This is all of the trials ever done on triglyceride lowering. You see how flat this curve is. If there is risk reduction from cholesterol lowering, it's not very impressive. Additionally, the main trial that's driving that tiny benefit I just showed you was with Vascepa, icosapent ethyl. The problem with this REDUCE-IT trial is the placebo arm got mineral oil, and mineral oil is known to cause heart attacks and strokes. So they compared a drug to another drug that causes heart attacks and strokes and said, look, our drug had a benefit. Tough. Some people talk about whether or not it's the EPA or DHA, and this is an all EPA formula, Vascepa is an all EPA formula of fish oil. However, this is from Twitter. What used to be known as Twitter is now X. They haven't released this trial yet, but you can see the repeat study on Vascepa, very, very narrow margins. Point being, let's take a big step back. If this helps, it only helps a little bit. And what I tell my trainees is, if something's this hard to prove, if it's this hard to prove that steroids in the MICU, medical ICU, are helpful, well, they could be helpful, but they're not very helpful. And that's how I think about triglycerides. So here's what I say. I drive down LDL and ApoB as low as I can. Very low. I use all the drugs that I can, and I lower LDL because I know it's bad. I treat metabolic syndrome and diabetes with drugs that you're going to hear about in the next talk. I use nutrition when that's available to me, when a dietitian's available to me. I tell them to move a little bit. I tell them to cut back on the alcohol. And if triglycerides are still up, particularly at pancreatitis levels, I treat it. If they're just a little bit up, shared decision-making conversation. These patients are already on a lot of medicines, and so telling them we're going to lower your triglycerides from 200 to 100, I'm not sure if it helps. That's a tough sell. Last thing I'll mention, and I'll do this quickly because I think I'm at time. Family history is very difficult. And it's very difficult because, A, patients don't really understand their family histories. B, half the time, dad who had a heart attack or stroke smoked for 60 years. Was it the cigarettes or was it genetics? I don't know. That said, when we look at big pools of data, we notice patients that have a family history do worse. They do worse. But it's a very difficult thing to measure and pin down if you have a family history. So the American guidelines, the AHA, have recently endorsed this concept of a polygenic risk score. The majority of cholesterol disorders are not a single gene. They are multiple genes that are acting together to cause badness. The concept behind a polygenic risk score is I will score all of your intermediate risk genes and then tell you what I think your genetic risk is, since it's so unlikely you have a single gene. It works, and occasionally it's very helpful. So I had one I sent in clinic the other day, and it came back and the patient said, the polygenic risk score said, whatever you're assessing their risk to be, it's 2 times higher. But when we look at the big studies on these, only about 4% of patients will have some reclassification of risk after getting a score. So when do I use this test and when am I thinking about this test? It's about $150. It's a cheek swab. It's $150 US. It's a cheek swab that they can drop in the mail. If it's a young patient who's got a confusing history, I offer it. I'm not using it a lot yet, but I think it's coming. There was just a big paper, however, that showed a lot of validity in these test scores in Southeast Asian cohorts, so it is a reasonable thing to order in this region in the appropriate patient. Just one other aside, though, because I've already talked to you about genetic screening once. If you have a heart attack or stroke before age 45, there's a 5% chance you have an inherited cholesterol disorder. There's an 18% chance that you likely have an inherited cholesterol disorder, and there's a 26% chance that you might. We're going to treat you for your heart attack or stroke, but you can't forget about families. So back to families again. If somebody has an early heart attack or stroke, think about their families. Okay, so we said, let's pick a target. Let's make sure we got there. Let's see how healthy the blood vessels are. Let's treat comorbidities. LPA, inflammation, triglycerides are all markers of risk. Some are easier to treat than others, and family history is tricky. I frequently get asked these questions at the end of this particular talk, so I will just tell you my approach to cholesterol lowering, and then we'll move on. So I pick a goal. I ignore 100 as a goal. I pick 55 or 70. I usually start a high-intensity statin. Crestor is great for younger people because the half-life's quite long, and so they can miss medicines, which young people are prone to do. Keeping in mind, if someone says they're intolerant, twice-a-week Crestor is 25% lowering. So you can use Crestor twice a week in your patient that gets cramps. Pravastatin might have the fewest side effects. I usually have success with this, though. Most people, I can get them on twice-a-week Crestor. I add Zetia quite frequently. And if they're still not at goal, PCSK9 inhibitors in America have become affordable. They're about the same cost as Jardiance, an SGLT2 inhibitor, empagliflozin. So they've become much more affordable in America. And there's a PO version that's coming out. You know, bempedoic acid is a difficult subject for me. It lowers much less than PCSK9 inhibitors and costs the same amount. So I don't use it a lot. I use it in people that are super scared of needles. Trypanophobia. Bile acid sequestrants work, but like niacin, not many people can tolerate them. An important thing that's forgotten, again, is lifestyle, can be another 20%. And we have a very exciting drug in America that's now available in multiple countries called inclisiran, that's in the PCSK9 pathway, but it's a twice-a-year injection. And so you can imagine, you come to the doctor's office, you get your flu shot, you get your COVID shot, you get your cholesterol shot, you head on your way. It's a very cool mechanism. PCSK9, as we know, signals for degradation of the LDL receptor. If PCSK9 is there, it says, throw this in the garbage, throw away the LDL receptor. You get rid of PCSK9, your own LDL receptor keeps clearing. What inclisiran does is it has perfect tropism for the liver. It only goes to the liver. Within 24 hours, it's not detectable anywhere else. And then it silences the gene, the mRNA, that makes PCSK9. Stays there for 6 months, 2 shots a year. All right, so please pick a target. Please think about lifetime risk and cumulative exposure to cholesterol. Think about coronary calcium score as getting an exact glimpse at how healthy blood vessels are. Treat comorbidities and keep searching for residual risk, particularly in the patient who's had multiple events. We had a patient that Chad and I both saw in the hospital a couple weeks ago who had a heart attack at 41, 39, and his LDL was 60, and they said, there's nothing else we can do for you. His LPA was 600. It was the highest LPA I've ever seen. Whole family trees littered with heart attacks. That's the kind of patient you send to an LPA-lowering trial. Keep looking for risk. All right, with that, I'm going to pass it on. I appreciate everybody's attention, especially after eating. Thank you.